Good. So as you can see, the stone there in the middle, that's the 1 centimeter stone that they're talking about on the CT. The wire was in perfect position. There's a lot of, we've swept on the distal CBD side, and we have that remaining 1 centimeter stone. The balloon catheter, there was a lot of resistance on advancing. So that kind of made the decision of sphincteroplasty a bit more difficult because we don't have a stable position to advance the balloon catheter. So what we decided to do is we're going to try to advance the cholangioscope here to kind of visualize the stone and try to perform some endotherapy such as EHL or laser depending on the stone, and then we clear. Now, the issue with the sphincterotomy site there is small, but I think we should be able to go in without a wire. So here I'm advancing the spy catheter. Good. Good. So
can we switch?
As you can see, I'm inside the bile duct now. Yeah. Can you guys see the spy picture? Good.
So in the fluoroscopy, the stone is actually more, bigger than the shaft diameter. So it's around actually 2 centimeter elongated stone. Still some of them can be out with the CRE balloon. However, the patient has peri and pillary diverticulum. So going with the cholangioscope and the size is 2 centimeter, I think will be the best option. And the stone is completely obstructing the CHD because we could not advance the balloon beside the stone. So
as you can see, guys, here just quick interruption. There's the cystic duct, and beneath is the common bile duct. And you can see here on fluoroscopy, that's exactly the direction of the cystic duct. So it's good to know because sometimes hospital
millimeter away and use saline or water medium to conduct the shocks. That will be a little bit different. Now we are using the EHL.
So the issue always as well is when advancing EHL or laser, especially higher up there in the common bile duct, especially higher approximately around the bifurcation, is that there may be a little bit of resistance advancing the EHL catheter, and that usually is very common. And then you have two approaches. Either you try as much as possible to unlock all your wheels, get the catheter out, and then go back to where we are right now, because again, most of the time this is too good to be true to get there and try to get the EHL smoothly. So sometimes we get the EHL out in the duodenum, and then we go on with the SPY again and try to give therapy. Sometimes if you give it a bit of resistance or a tug, a strong push, the EHL catheter will go inside. But it's a very delicate catheter, so we have to avoid injuring the catheter itself. Okay, it's not going.
So a little bit of resistance, so we may pull back the cholangioscope.
Let me see here.
I have the fluoro.
Okay, so first let's try to unlock here. Okay, so there is a lot of resistance. So I'm going to unlock my spy wheels. That may help elevate, and I'll try to go sometimes a bit long.
Can we also have the fluoroscopy picture, please?
Into the CBD, and we've already tested the EHL and shocked the stone a bit, and then we stopped to kind of get you guys back with us on live. So EHL, we use water as medium for the electric shock, and Dr. Adel here is going to help me with shocking as well while I direct the EHL catheter. We have to stay a bit away from the stone because the EHL catheter can break, so we want to do a contactless shock wave into the water medium. So that's good. Yeah, good. So we'll push it out so it doesn't. 1 second. Good. Let me pull back the spy. Good. 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 Go. Go. Go.
So one of the tricks we had to do. Sometimes when the catheter is difficult to get it out from the cholangioscope, we had to bring the cholangioscope out from the CBD, and then we advanced the catheter and went smoothly until the tip of the cholangioscope. And then we cannulated the bile duct with the cholangioscope loaded with the EHL wire.
Go.
And another trick in this case, so this patient, she has periampulary diverticulum, so we also elected to do the cholangioscope instead of large balloon CRE PRE dilatation to avoid any complication with periampullary diverticular.
So I think this stone is kind of well fragmented, so we're going to go further here to go to more proximal stones. So go, doctor. Good. So try to stay away from the bile duct here. So this is a nice stone here on top of me. Go, doctor. Yes?
There's a question from the audience.
Yeah.
What is the EHL setting?
So the setting is medium. So we have low, medium, high power.
And
we
pulse at
have-
30.
Yeah, we have 10, 20, 30 pulses. So we use medium power and 30 pulses.
Go.
And what about for laser?
So we're using here more, we have a pre-setup of the laser catheter. In all honesty, we just hook it to the system here, and then we try to kind of get the laser therapy as short as possible in terms of pulses. We have low, medium, and high. We usually put it on medium on our system.
And we can always go higher or lower if need. So we'll probably never go lower, but we usually need to go higher. So that's why we can kind of start off low and medium and then go to high power if needed. If we put low or medium, then we increase the pulses. But now we are in medium, so we put the pulse into the 30 maximum.
Yeah, these systems that we have here for both the EHL and laser are pre-set up into low, medium, and high. Sometimes, if you want the catheter to stay longer, we put it on low so that it gives us a longer half-life of the catheter. And we put it on high if we have a single hard stone, such as in the pancreatic duct. But let's say these patients who have multiple CBD stones, on laser and EHL, we try to go medium or low so that the catheter gives us the longest half-life. Good, 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 good.
So again, to position our cholangioscope, so we mainly use the wheels, the cholangioscope wheels though. However, sometimes we had to just manipulate with the shaft, like what Dr. Saad is doing sometimes, to get you centralized into the in front of the stone.
This one is larger.
Because you know it's one of the risk is causing injury to the bile duct wall.
Good.
So positioning is one of the main, and the most important thing also a good visualization. So sometimes the bile duct wall look like a stone. So you just keep crushing and you never know what's really behind the stone, especially like big one like this causing complete obstruction. We need to be careful with the pulses, and each time we do a shock pulse, we also put water just for good visualization to make sure that we are not touching the wall, especially the wall distal to the CBD.
Can we open
stone.
the section, please, for Spy?
So yeah, I can help with that. Yeah, no problem.
Yeah. So I think here with pulse of 30 and EHL power of medium, it's giving us very good results, to be honest. And I think this is probably the fragmentation of the stone that was giving us a lot of difficulties on the wire. And to confirm that, we can see where we are on fluoroscopy. And that coincides with the stone that was giving us a lot of difficulties earlier. So hopefully now, when we can try to advance the balloon and try to sweep, we'll try to sweep the distal debris first. And then we'll try to remove these fragmentations of the stone. Now it's very important that these patients get antibiotics and that they're intubated because of how much the amount of water that we're using into the bile duct. And so yeah, antibiotics, intubation, and then we leave them with a stent. Why do we leave them with a stent even if we remove all the stones? Is because even when you remove and sweep all the stones under fluoroscopy after, with such fragmentation you will have a lot of debris. And sometimes patients have post-cholangioscopy bacteremia, for example, or cholangitis. So that's very important to keep them with a stent right after this procedure to prevent that complication.
So we are now almost at the bifurcation. I think we can see the beginning of the bifurcation here.
Yeah.
We'll just try to see whatever fragment we have here. Is it? Yeah. So
Good.
yeah. So that's the bifurcation. I think it's all now fragmented. So what we can do is just take off the cholangioscope and then sweep all these fragments out. We may need now to do a CRE, but not really a large diameter dilatation because we already fragmented the stone. The patient has benign distal CBD stricture. That's what we also noticed in the earlier fluoroscopy image. So we're probably just going to dilate to 10 just to allow these fragments to come out, and then we'll clear the CBD from the stones, and then we place a plastic stent, probably 10 French, 10 centimeter, and we'll give patients antibiotic as the cholangioscopy require antibiotic also after, like Cibro if she's not allergic for 3 to 5 days.
So another thing also, it's very important, like Dr. Adel suggested, also performing sphincteroplasty sometimes before SPY may cause the papilla to be very bloody, and advancing a SPY may be more difficult. But now that we're seeing all this, it's very important to examine after. The hard part is not pushing the EHL, it's examining after. Making sure all the stones are floating, making sure you don't have to come back again, and careful withdrawal. I always say it's like withdrawing in colonoscopy. You have to examine every segment to make sure there's no larger stone, because as you know, especially in this patient, there are multiple stones. You want to make sure that really the stone that was giving you trouble has been targeted. So here, this is a cystic duct.
Yes, Ammar.
We have 2 more minutes to stay with you, so yeah, you can.
Yeah, so that's the cystic duct here. We're withdrawing. The CBD was examined very well. All the stones that remain are fragmented and floating. So I think that's a pretty good result.
So yeah, so I think we finished with the main part. So if there's any question, we're happy to answer. Now we are just coming out with the cholangioscope. We fragmented all the stones, so we will come out with the cholangioscope and put a wire with the stone extractor balloon just to do a sweep.
So
There's another one here. We just crash it.
That's the importance of withdrawal. Careful withdrawal. There are too many suspects here in the bile duct. But I think this is okay. It's a kind of not that big.
Yeah, it's already crashed with this one.
So this is a very nice case. We went through all the challenges of EHL in elderly patients. J-shaped stomach, advancing the catheter into the bile duct. I think it gives you more real-time use of cholangioscopy. And we're very happy to participate in this. And thank you so much. And if you have any questions, I think we have a minute left. Yeah. Thank you. Okay, I think that's pretty good.
Thank you for the